Welcome to the conference session titled MDS MPN Overlap Syndrome. Thank you for joining us. My name is Alice Hauk, Senior Director of Patient and Professional Services at AAMDSIF, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your health care. Today's specialist is Dr. Ruben Mesa. Dr. Mesa is the Executive Director of Mays Cancer Center, home to UT Health San Antonio MD Anderson, one of only 4 National Cancer Institute designated cancer centers in Texas. For almost 30 years, the Cancer Center has had a deep focus on providing world-class cancer care, advancing cancer research, and educating the next generation of cancer care scientists and care providers. Dr. Mesa's practice builds on his role as an international expert on myeloproliferative neoplasms, a group of bone marrow disorders that often lead to leukemia. He has been involved in MPN research for more than 20 years. Dr. Mesa has been the principal investigator or co-principal investigator of more than 70 clinical trials. He co-led the research team leading to the FDA's approval of ruxolitinib for polycythemia vera and myelofibrosis. He is currently leading the investigation of several other drugs for these types of cancers. Welcome, Dr. Mesa.
Hello. Again, my welcome to those that get a chance to hear me set up some welcoming words earlier this morning. Hope so far that you're settling in well and that this will be a productive and interesting session for you. So first, let me go ahead and share my slides here. Alice, are you able to see those okay?
Yes, we're seeing them. Thank you.
Wonderful. Well, today we're going to be talking about the MPN MDS overlap syndromes. And again, as the name might imply, that is quite a confusing terminology for quite a number of individuals. And so I'm going to help to try to demystify this to the best degree that I can. This is an interrelated group of diseases that share a variety of features, but sometimes with some very different disease types, different ways that you're affected, different treatment options that we consider. So this is a very individualized type approach that we usually have to face with diseases like this. So first, let me back up. When we say MDS, we're speaking of myelodysplastic syndrome. This is a type of bone marrow disorder. It is a type of a chronic leukemia. So what do I mean by this? When we use the term leukemia, it is a term we've heard. It's a term that usually conjures up images of individuals that are very ill, possibly images of children, possibly of chemotherapy or a life-threatening disease. The term leukemia truly means any disease of the bone marrow that is a type of a bone marrow cancer. Now, again, cancer itself is a very emotive word that conjures up all sorts of images. such as breast cancer or colon cancer. It is very different. Cancer technically means any disease where our body is making more cells than it should be, and they have the potential to spread to another area. So we have some cancers that can be very serious and other cancers that are very much less so. We have certain skin cancers on one end of that spectrum and other cancers that can be very life-threatening. The same is true with leukemias. The word leukemia, again, means a disease where in the bone marrow we're making cells that we shouldn't be. And it can range on one spectrum of diseases that people may have for many years and live out their normal lifespan. Or on the other hand, diseases that can be life-threatening. Under that umbrella of leukemias, there probably are 40 to 50 types of diseases that range from what we call chronic leukemias to acute leukemias. Now, acute leukemias, as the name might suggest, are diseases that can be very life-threatening, can be aggressive, and constitute some of those appropriate images that you have. Acute leukemia. My apologies, I have an old-fashioned non-COVID cold that I'm battling this morning. But on one hand, we have the acute leukemias. Now, about 40 of those 50 diseases are what we call chronic leukemias, of which both myelodysplastic syndrome and myeloproliferative neoplasms are two types of chronic leukemias that individuals can face. So the myelodysplastic syndromes are a group of interrelated chronic leukemias that, one, tend to lower the ability of the bone marrow to make the blood cells that we need. The entire reason we need bone marrow is it makes our blood. It makes the red blood cells that carry oxygen from our lungs to the rest of the body, the white blood cells that fight infection, the platelets that help the blood to clot. Any decrease in one, two, or all three of those can have a negative impact for the individual that is affected. Anemia, or a low red blood cell count, is by far the most common of those cells to be affected. Now, the name came from many decades ago, even into the 1800s, when pathologists, who are medical experts who look at blood under the microscope, thought that in the blood and the bone marrow there was what they called dysplasia, that individual cells looked abnormal. They were different in terms of the size or shape that they should be. Now, the myeloproliferative neoplasms are a cousin of the myelodysplastic syndromes. Here, the issues are different. It can be the creation of too many blood cells. The body doesn't like too much or too little of anything. It needs to keep what is necessary in a certain range. There can be an increase in the blood counts. It can lead to difficult symptoms. It can lead to an increase in the size of the spleen. The spleen is an organ under the rib cage on the left side that acts as a filter for the blood. So there are individuals out there who have myelodysplastic syndrome. They have low blood counts. They've been diagnosed based on changes in their bone marrow. And Dr. Amir Zadan is going to speak later today about myelodysplastic syndromes. They have a risk of progressing to acute leukemia. On the other end, there are the myeloproliferative neoplasms. These are diseases like polycythemia vera, where we make too many red blood cells, essential thrombocythemia, where we make too many platelets, myelofibrosis, where we can have scarring in the bone marrow and an increase in the size of the spleen. Even chronic myeloid leukemia, where we have too many white blood cells. Individuals that have an MPN, MDS overlap syndrome are individuals that the features of their disease are somewhere between these two types of illnesses. It does not mean that you have two diseases. I frequently see that either patients can be confused by this point. It doesn't mean that you have both myelodysplastic syndrome and an MPN. You only have one illness, but the illness has features of both, and that's why it's been labeled as such. Now, again, more information about MDS. We'll talk a little bit about each of the two types of diseases so you understand why they sit a bit in the middle, and then we'll go through some examples of some of these illnesses. In the MDS, how we classify that as different than the MPNs is you do not tend to have enlargement of the spleen. It's less likely to cause certain symptoms. Fatigue can be present across this entire spectrum of illnesses, but other symptoms such as itching, night sweats, weight loss tend to be more specific for myeloproliferative neoplasms. In the blood and bone marrow, there are differences that your doctor and the pathologist use to distinguish between them. We increasingly learn information about the genetics of these diseases, both from genetic tests that they're able to do when they do the bone marrow biopsy, but also from the blood, where there's changes in the genes that give us more information about the disease. The other end of the equation, the myeloproliferative neoplasms, more likely to have symptoms, more likely to have an increase in counts, an increase in the size of the spleen, different changes in the bone marrow, including scarring and fibrosis, and different genetic changes, frequently very specific genetic changes in certain genes that are associated with this disease. These changes tend to lead to an increase in the overproduction of blood cells. Individuals that have an MPN MDS overlap syndrome, or they tend to have features of both. So they will tend to have the potential of low blood counts. They may or may not have an increased size of the spleen. They may have some degree of dysplasia. So that is a change in the individual types of cells. And they have certain genetic changes as well that give them a link to either, or usually both, MPN and MDS. Now, within this category of MDS, MPN, we have several kind of subgroups that are each, quote, rare diseases in and of themselves. Again, one key thing is to recognize that these diseases live on a spectrum. And as treating hematologists, we are very mindful of how the disease is affecting you as an individual. And likewise, we try to understand, is the disease behaving more like MDS, more like an MPN, or somewhere in the middle? The reason for that is that we have FDA-approved treatments for MDS. We have FDA-approved treatments for MPNs. We do not yet, at this point, have FDA-approved treatments for the MDS and MPN illnesses as an isolated group. There clearly are medicines that we use for these illnesses, but it very much depends on how the individual is affected. Are they having anemia? Do we use medicines that help to improve anemia? Is the disease moving toward acute leukemia? And our goal is to try to avoid that. Are there symptoms or enlargement of the spleen? There are efforts ongoing to try to develop specific clinical trials for individuals that have MDS, MPN overlap. And indeed, one of my colleagues, Dr. Mike Savona from Vanderbilt, has helped to organize an international group of which I am part that specifically are trying to develop trials for individuals with these illnesses, create greater awareness, and understand which therapies might be most effective. Now, the most common subtypes that exist within this umbrella is 1, chronic myelomonocytic leukemia, CMML. Second, atypical chronic myeloid leukemia, juvenile myelomonocytic leukemia, MPN, MDS with ring sideroblasts. Now, again, I recognize these names are very complex. They can be very confusing. They really were not designed to be patient-friendly. These were names of illnesses really derived by medical nomenclature that largely describe what is being seen under the microscope or in the blood. There are individuals that have these diseases that don't fall into the exact diagnostic category of one of these other buckets and are put in this category of unclassifiable. Again, try not to let the complexity of the name overly confuse you or be distressing. The key is we judge really how the disease is affecting you as an individual and try to get past this awkward nomenclature. Now let's think about these diseases overall. 1, how serious are they? It really depends on the individual, and we'll get into how we try to assess that. Second, how does it affect you? It may affect you in terms of lowering the counts. If you're anemic, you may have more shortness of breath, you may need transfusions. It could affect you in those ways. If the white blood cell count is low, there could be risk of infections. If the platelet count is low, there could be risk of bleeding. If the spleen is enlarged, it could cause discomfort. If there are symptoms that can clearly impact your quality of life. These diseases have some variable risk of progressing to acute leukemia that range from being very unlikely or to never occur to all the way being highly likely and making the disease more life-threatening. They are chronic diseases. So in general, they are diseases that yet in 2022, we do not have an easy cure for. That clearly is our goal. Make no mistake that research is going on around the world to try to understand how all of these diseases of the blood, how they occur, why, how do we develop better treatments, how can we cure them? Now, in 2022, the only cure we have for diseases like this remains bone marrow transplantation. And when I say that, it is the equivalent of stem cell transplantation. Those are largely 2 synonyms we use for the same treatment. One, the cells come from the actual bone marrow, harvested from the bone marrow of a matched donor. In the other, we obtain the cells from their peripheral blood that are filtered out. But for the patient, it is the same treatment. Bone marrow transplant is where we give the individual typically chemotherapy to suppress the immune system, to help to eradicate the underlying disease. And then they receive the bone marrow from someone else to help to reconstitute the bone marrow, and also to have the new bone marrow recognize the old bone marrow as potentially harmful and have an immune-based therapy really against that residual disease. It can cure the disease, but it's a very complex therapy. It involves significant time in and out of the hospital. It involves a very intensive period of medical care over 3 months to 6 months. It involves the potential of life-threatening complications. And because of that, it is a therapy that we use very selectively. Now, as we try to treat MPN MDS, the majority of time we are using medicines. We will consider stem cell transplant, but because of the complexities that I just mentioned, we tend to think about it in situations where, one, we think the illness is life-threatening in the near future, and two, we think the individual is of an age and a fitness where it's likely to work well for them. Now, as we try to develop a treatment plan, we really focus on what are our goals. Is it to cure? If so, only transplantation is an option with that as a goal. Is it to reduce symptoms or enlargement of the spleen? Is that a factor in your disease? Is it problematic? Is it to improve the blood counts? Are the blood counts low enough to be causing a problem? Do they cause you symptoms? Do they put you at risk? Is it to improve molecular features of the disease? Probably that would not be a goal in isolation, but might be a goal as our therapies evolve. Is it to avoid disease progression? There are currently very few evidence-based recommendations, meaning based on the basis of clinical trials, for these subsets of MPN MDS other than for CMML, which has been one of the most common. Now, one of the key things our physicians do, and I was involved with helping develop this educational sheet for treating physicians with other colleagues for both AAMDS International Foundation as well as the MPN Foundation, was recognizing that in each of these diseases, there are features that give us a sense of how life-threatening the disease might be. There are features, and you'll find information on this on the AAMDS-IF website, prognostic features for people who have MDS, prognostic features for people who have an MPN. People that have an overlap syndrome, again, a variety of different prognostic features. Now, what prognostic features tell us is they give us a sense of how life-threatening an illness might be in an individual. It is never perfect. It is probably better at estimating. It gives us a sense. Is it lower risk? Is it higher risk? In any particular circumstance, we could see one individual who has a higher risk disease, but their disease may progress slowly. Or on the converse, there are individuals that have lower risk disease that their disease might progress more rapidly. So it's all somewhat individualized, but it does give us a helpful sense. I like to consider, when I am trying to come up with a treatment plan for a patient, both their disease risk. How likely is this disease going to be life-threatening? How likely is this disease going to shorten the life of the individual that has the disease? We all eventually pass away from something. So in medicine, what we really think about is what can lead to something shortening your life over where it might have been otherwise. Because based on genetics, our fitness, and other things, our life expectancy might really be quite variable. So, well, our real goal is to try to avoid the blood illness, really prematurely ending an individual's life. So let's start with chronic myelomonocytic leukemia. So first, let me very clearly state that this is a very different disease than one whose name is very similar. There is a disease called chronic myeloid leukemia, or CML. That disease is an MPN. That disease has a very specific genetic change called the Philadelphia chromosome that leads to a protein called BCR-ABL that now has several drugs approved to treat that disease. That disease is completely different than this disease. That disease has a very different way to treat it. Being sure that which disease an individual has is critical, because if we use the therapy for CML, for CMML, it is not effective, and vice versa. So it is clearly not uncommon for someone with CMML to Google or do a literature search and find information on the wrong disease and create great confusion. So be very, very specific if you read about this disease, that you are reading information about chronic myelomonocytic leukemia. I would not dispute for a moment that if we were to rename these diseases all over again, we would give them much more different names because it creates confusion. Now, the origin of the name is really around one subset of cells within the bone marrow called monocytes. It is one type of cell that is a precursor of the white blood cells. And it is also found by physicians because it has these features of dysplasia, which means they look abnormal. This is the largest subset of patients with MPN MDS overlap. Now, even within CMML, there are individuals that can have features more like MPN or more like an MDS. So everyone with CMML is not the same. Some have features more like an MPN with night sweats, weight loss, and large spleen. And others will tend to have issues with really low white cells, red cells, and or low platelets. So that is one factor we consider in terms of the illness. It's not a common disease, less than one person per 100,000 per year. It is common as we get older. We do note that there are more monocytes in the blood, a subset of the white blood cells, than there is supposed to be. And hence, it was really a chronic monocyte leukemia. It very specifically does not have the genetic change that we associate with chronic myeloid leukemia. And the main difference that we distinguish this is, again, it's a different biology and a very different treatment. We see that there are changes in more than one line. By line, I'm referring to the red blood cells, the white blood cells, or the platelets. Now, increasingly, we obtain information about genetic changes. These are genes that are all different sorts of on-off switches that are involved with how cells are controlled. That we can have genetic changes that are some of the underlying drivers in these diseases. You might recognize some of these names, as your doctors will typically be obtaining panels of genes that may or may not refer to the presence or absence of any of these mutations. Over time, these increasingly will give us more information on both diagnosing and treating the disease, as well as having therapies that may have an impact for them. There are different features that can give us a sense of risk for an individual. Again, risk being how likely is the disease to be life-threatening. And this can help to factor in, do we consider an aggressive treatment such as bone marrow transplantation in the near future or not? We also look at how close is it to acute leukemia. Acute leukemia is defined as having in the bone marrow over 20% blasts. Blasts are the earliest cells in the bone marrow. You can think they are like the seed, and the seed grows and matures into many cells over time that once mature go out into the bloodstream and become red blood cells, white blood cells, or platelets. Normally, our bone marrow has some blasts, but they are typically less than 5% of the cells. Once we see that that number has truly increased above 5%, 8%, 12%, 16%, we feel that we are moving towards acute leukemia. Why that matters is we consider acute leukemia to be much more acutely life-threatening than chronic myelomonocytic leukemia. It's just showing the difference that these diseases can have in terms of how severe they can be, in terms of how long an individual may live with the disease. Now, all of these things evolve very rapidly. The improvements in new therapies, better ways that we help to support patients. Individuals are living much longer now with these diseases than they have lived in the past. How do we treat the disease? It continues to evolve. It is very much matched with how you are affected. If you are lower risk and have no symptoms and the counts are not too bad, we may actually observe the disease for a period of time. Or if there are a drop in the red blood cells and anemic, we have medicines that may help with that. There's higher risk disease. We have therapies that can be utilized, such as azacitidine or decitabine. Some of you may be on this for these illnesses or others. We can consider therapies on clinical trials and frequently do try clinical trials to be evolving to be more effective therapies. And finally, we can always consider stem cell transplantation. There certainly is good benefit that can occur in individuals with what we call hypomethylating therapy, which is both azacitidine and decitabine. And now there are oral versions of both of those medications that can help to delay progression to acute leukemia, that can, in certain circumstances, improve the low blood counts or help individuals live longer with the disease. As I mentioned, stem cell transplantation can cure these diseases. It is complex. Individuals have been heterogeneous. So it's difficult to know for one individual how likely is that to be successful. The success rates are sobering. They clearly can lead to people being cured. I will tell you, because he's very public about it, my boss, the president of the University of Texas in San Antonio, William Henrich, is a transplant survivor who in his early 70s had a haploidentical transplant, meaning a half-matched transplant, that cured him of his high-risk myelodysplastic syndrome, like a CMML, was cured and continues to lead our university. So there clearly are successes. There are many ongoing clinical trials that are ongoing. And again, more things for us to learn over time. I think as we continue to learn more about the subsets of these diseases, try to match them with individual features of your disease, that will help us further as we try to develop targeted approaches. There's atypical CML. Now, this is a name that I think is very confusing. And I do apologize, but not being the origin of the name. I say this because it is a completely different disease than chronic myeloid leukemia, which is why it's called atypical CML. But it does not have the BCR-ABL. The therapies for CML are not helpful in this condition. It truly behaves quite different. The blood counts are increased. It has different genetic drivers. Over time, we may hopefully develop a genetic therapy for this disease. It too can have enlargement of the spleen. It has this term here, dysgranulopoiesis, again, a very medical jargon name, but referring to that the white blood cells look atypical. They look different than they should. And very importantly, they do not have the BCR-ABL. The medicines that impact BCR-ABL are not going to be helpful. It has been found that there are very specific genetic changes in these diseases. Now, they have not yet led to a specific treatment that is able to impact ZBP1 or CSF3R, but I do believe over time that likely will occur and allow us to have more targeted approaches. This disease can be more life-threatening. This is one where we will tend to be more considering of stem cell transplant for appropriate individuals. It is a disease individuals do tend to be older when they are diagnosed, and one where we do consider clinical trials most certainly if available. This just showing here the significant impact of this genetic change in ZBP1 that again gives us both a better sense of the risk with the disease, but as well as suggests we clearly need better approaches to be able to target these genetic changes. Our treatment certainly overlaps with the sorts of treatments that we have considered in CMML. We can use medicines to try to improve symptoms, usually with relatively modest success. There have been clinical trials of combination of therapies with JAK inhibitors ruxolitinib in people that have had the JAK mutation with some success. There have been other inhibitors of protein pathways called kinase inhibitors that are ongoing. It certainly, stem cell transplantation has had a benefit. For a subset of individuals. Again, this is not a common subset of individuals, so the total amount of data is limited. Now, this is a mouthful, but it is a real entity, an MDS MPN with ring sideroblast and thrombocytosis. Again, the name, I do apologize. It truly is almost absurdly complicated in naming. Think of it as a chronic leukemia that has too many platelets, but also has some features of MDS. And with that, again, how we treat it depends a bit on how it's affecting you. Some people have a lot of anemia, some people less so. Some people, the platelets are increased, and we are concerned about a higher risk of blood clots and need to control that elevated platelet count. Again, as with these other diseases, they do tend to be diseases of older individuals. There is a greater likelihood of a certain set of genetic changes, such as the SF3B1 mutation. There do tend to be symptoms associated with an increase in the blood counts. We diagnose this disease, again, based on changes in the bone marrow, in the bloodstream, and increasingly identification of these molecular changes, such as SF3B1. We see that, again, some of these genetic changes may end up having implications in terms of therapy. We currently have a therapy called luspatercept, which is a medicine that can help with anemia that is approved in MDS, that has been helpful for individuals that have the SF3B1 mutation. And here again, just showing more information is, again, we try to understand individuals that have higher versus lower risk disease and who we might consider for more aggressive therapies such as stem cell transplantation. We treat this, again, depending upon how an individual is affected. If it's primarily around anemia, we treat it in many ways as we do anemia for patients with myelodysplastic syndrome, with consideration of more aggressive therapies such as stem cell transplantation for individuals with more progressive disease. And then finally, there are times that the pathologist is not able to appropriately attribute the disease into one of those categories, but it's kind of somewhere in the middle. MDS, MPN, unclassified. Now, for some individuals, this has created the confusion of saying, well, do I really have a disease? What does this really mean? Truly, you could think of these diseases as a spectrum. I sometimes have used a geography analogy. Let's say if we use the state of North Dakota and South Dakota as a geography model. And the further north you go, if you go far enough north in North Dakota, you hit Canada. If you go further south in South Dakota, you're in another state. Now, having a chronic leukemia puts you somewhere in the Dakotas. Having an MPN, MDS puts you somewhere near the border of South Dakota and North Dakota. North Dakota was MDS and South Dakota was an MPN. And depending upon where you fall in that geography, leads you somewhere in terms of, what city you're in, what county you're in, helps refine further really where you are. Illnesses like this, it's really somewhere like that, where again, it's somewhere in between. It doesn't mean that you have more than one disease. It doesn't necessarily mean that the disease is worse. It just means that it doesn't fall into one of those other pre-specified buckets. So this, again, by its nature, means that it doesn't really fall easily in one of the other categories. It doesn't have enough monocytes to call it CMML. It does not have enough dysplasia to call it atypical CML. Again, like the rest of these illnesses, tends to be a disease that's a bit more older, tends to have mixed features, spleen, symptoms, genetic changes. It can be a serious disease. Like the others, it can be a consideration for more aggressive therapy, such as stem cell transplantation or other approaches, depending upon how it's affecting you. It does tend to have a higher rate of these additional genetic changes that may have implications in terms of both therapy and new therapies in development, new potential clinical trials. There is not one specific treatment, but we use many different treatments, really depending upon how an individual is being affected. Finally, I'll mention that there are significant efforts to try to develop new approaches across this spectrum of diseases. So Dr. Savona is leading this MDS MPN International Working Group, of which I am a part, that are looking at different combinations of therapies for individuals across the spectrum of these diseases, so that we could, since they are not common, we could try to study them together rather than do individual trials for individual subsets of patients. So let me leave you with these conclusions and then try to answer a few questions. This is a spectrum that can range anywhere from MDS to MPN and anywhere in between. The diagnosis is both your clinical hematologist and pathologist working together, typically with additional genetic information. The changes in the counts can make both diagnosis tricky, but also can make treatment decisions challenging. Sometimes trying to lower the white blood cell count can be tricky in the setting of a baseline low platelet count. Medicines like azacitidine, decitabine, ruxolitinib, and others are commonly used. For younger individuals with higher risk disease, we tend to consider and favor early consideration of bone marrow transplantation. I think over time, we increasingly will have more directed therapy depending upon your genetic changes with your disease that hopefully will lead to more effective therapies. And with that, let me stop sharing those slides, but open it up to any questions that may have arisen.
Thank you, Dr. Mesa. We do have a few questions. One is, what does 5q mean?
So 5q minus refers to the 5th chromosome. So one of the genetic tests that are done when we have a bone marrow biopsy is something called cytogenetics. What that is that they look at the pairs of chromosomes, which is one way of looking at genetics in the cells. And normally there are 23 pairs of chromosomes, 1 through 23, and then the X and the Y chromosome that help to determine gender. So in women, there's normally 46 XX chromosomes, or in men, 46 XY chromosome. The 5th chromosome, chromosomes look like a big X, and they have the top part of the X. There's both the P and the Q arms of the chromosome. The 5q minus means that the Q arm on the 5th chromosome is absent. What that refers to is there's a specific kind of features of these diseases that can be associated with the deletion of the Q arm of the 5th chromosome. And there are certain therapies such as lenalidomide that sometimes have been helpful for individuals that have the 5q minus. So that is, again, you could think of one of the tea leaves that doctors use to try to understand the disease. One are cytogenetics, which was the older way that we looked at genetics, that they look at either with cytogenetics or sometimes they will do a test called FISH. FISH is where they use little probes to identify changes in chromosomes. The second and complementary approach that is more modern is where they do what's called next generation sequencing, or NGS, for specific genetic mutations such as JAK2, ASXL1, SETBP1, and both of these sets of information are things that your doctor looks at that may have implications both for diagnosis and treating your disease.
Okay, another question we have is, what is joint pain indicative of?
Joint pain can be a common symptom. It can have many things as a driver, so it's not indicative of one particular thing. So one, it of course can occur just as a process of us having, being older and having degenerative joint disease, but might be worsened by us being anemic or having high blood counts. There are times as well in these bone marrow conditions that we can have bone pain, where the bone marrow being overly active can actually give us discomfort in the bones. Now, that bone pain typically does not affect our joints to the same degree. That sort of bone pain that we might associate when we have high blood counts, we will tend to feel across the flat bones, like our ribs, skull, or sometimes in the middle of long bones, like in our legs, and not the joints. But I do find that joint pain can be a common feeling with MPN and MPN MDS overlap, or MDS, because it tends to make the potential of joint pain that we feel normally worse.
Thank you. Another question we have is, what is the significance of possessing or not possessing the AMXL1 mutation?
It probably is referring to the ASXL1 mutation. That is one mutation. It is one of the more common ones. And it is one that for most diseases, MDS or MPNs or the overlap, does tend to suggest a higher risk of potential disease progression. There are many scientists trying to understand, why does that particular mutation lead to a more difficult disease, and how can we target it more effectively? So more to come, but I do envision in the future clinical trials that will be specifically directed toward individuals that have the ASXL1 mutation, to see if we can make a better impact for that subgroup of individuals.
Thank you. Another question is, if an overlap transforms into leukemia, how quickly does it occur? Can you see it coming? Is there a surprise one morning?
This is a very good question. It can really be either. So what we have learned is that, progression is not linear, meaning individuals will say, well, my blast started increasing, they've been at 5%, and now a year later they're at 7%. Does that mean that I could graph out, the rate at which the disease will eventually hit 20% and I have acute leukemia? Unfortunately, it does not occur that way. We can either see, one, a slow progression, or two, a unexpected or rapid progression. And because of that uncertainty, if we have a high concern that the disease is going to change to acute leukemia, we do tend to consider that if we are going to consider our most aggressive option, such as stem cell transplant, that we do it earlier rather than later in the course of the disease. What we have learned is that if an individual does change to acute leukemia, our goal, if we're going to pursue a curative approach, is that we typically need to give chemotherapy to try to have the acute leukemia go into a remission and act again more like the chronic leukemia. And at that point, then do the bone marrow transplant. When we do a bone marrow transplant in the setting of acute leukemia, the likelihood of success, unfortunately, is quite a bit less. So wish that we knew for certain what that pace would be, but we do know that if that is a significant concern of that developing, we've learned to be more proactive in terms of trying to intervene with therapy earlier or more aggressively to avoid that.
Thank you. Our next question, where specifically is the most targeted research in this field of MDS-MPN overlap going on right now? Is there a funding constraint here? And if so, where can we as individuals make donations or contributions to promote or accelerate such research?
Wonderful. Well, without question, research is critical, and the AAMDS IF will be helpful in helping kind of guide you toward a range of places, including their own, that can really help steward that. Themselves, the Leukemia Lymphoma Society, of which I'm a national board member, the MPN Research Foundation, many kind of working in parallel, doing good work. I think the greatest area of focus, and appropriately so, is understanding why these diseases develop and progress. All of these issues really around these genes and the genetic changes, I think, are critical, because they will help us to guide the development of more targeted therapies, but also to be able to better match therapies with the individuals that have that particular circumstance. Based on your genetic changes, a therapy that ends up being helpful for yourself may be very different than a therapy that is helpful for someone else. So I think that is a key area of focus. The other thing that you clearly can do is, again, when appropriate, if there is a clinical trial, that is truly how we make advances. We only make advances by really being able to understand how new therapies or combinations of old therapies used in new ways, for individuals, how effective they are. Learning through that process is critical for us to make progress.
Thank you. Another question. Once blasts go above 20% and AML is reached, can they go back below that level?
Yes. So without question, they can go down, typically not spontaneously, but in response to therapy. So the 20% number, first, is not a magic number. It's an arbitrary number, meaning, is there really a difference between, let's say, 18% and 22%? There probably is not. Having significantly increased blasts mean the disease will behave more like acute leukemia. What really drives how severe acute leukemia is how quickly the blood counts really drop in response to that. Individuals with acute leukemia, what makes the disease life-threatening is not the blast, but is the secondary impact on not making enough infection-fighting cells, such as neutrophils, or enough platelets to help the blood to clot. So individuals with acute leukemia, what actually can take their lives is infection, and or bleeding. We certainly track the number of blasts as one of the areas of response as we're using treatments. So if we're using, let's say, azacitidine to try to impact the disease, bringing the blast down is certainly one way that we measure response.
Thank you. Another question from a patient. What does it mean when one's blood work doesn't rebound in the recovery period of Vidaza treatment?
This certainly can occur, that, again, therapy with Vidaza or decitabine really has two goals. The first goal is to try to prolong life. The second goal is to try to delay movement toward acute leukemia. The third goal is to try to improve low blood counts. There are times that, again, it can be slow in recovery. And depending upon the circumstance and how low the blood counts are, maybe something that we continue still the same pace of giving that therapy and provide supportive care with transfusions, etc., or will delay the time between between cycles. There are times we have used those therapies to delay movement toward acute leukemia, even if improvement in the blood counts has not occurred. The improvement in the, or delay in the time to progression to acute leukemia is not necessarily tied to the improvement in low blood counts.
Thank you. How often should a bone marrow disease patient have a bone aspiration test after diagnosis?
Depends on the circumstance. You know, in repeating it at some frequency is helpful because it gives us insight into the disease. You know, based on the aggressiveness or the risk of the disease, that may determine whether that's anywhere really from 3 months to a year, depending upon the disease. We also get a sense of if a therapy was started, that may lead to a sooner bone marrow to assess response. We also get a sense from the blood tests whether the disease is stable or progressing. But I would say anywhere from 3 to 12 months would probably be most typical.
Another question, few of these have been related. Oh, and you touched on this in your presentation, but if you could briefly review, what are the known causes of MDS and how long does it typically take MDS to develop into AML?
One, for the majority of individuals who have MDS, we don't have a clear cause. You know, for most individuals, it's not a question of, I did X or Y or Z and I developed the disease. Indeed, the biggest driver, we believe, is the process of aging. And that aging and the development of these disorders is very tied together. Did you saw with many of the ones I've alluded to, median age in the 60s to the 70s. Now, there are some underlying cases where we do have a driver. Particularly, we know certain types of chemotherapy that have been given in the past, sometimes for curative intent, can lead to a secondary myelodysplastic syndrome. Where there is evidence to suggest that certain toxin exposures from benzene, Agent Orange, or others, have been a driver. Potentially radiation therapy for a prior cancer. But in aggregate, that is probably still the vast minority. For the majority of individuals, it's probably not anything you did or were exposed to, but it is a consequence of the aging process that we are still trying to learn more about.
And can MDS go into remission?
MDS typically has not been able to be cured or gone into a remission defined as you see no evidence of the disease in the absence of a bone marrow transplant. It clearly can be controlled. Without question, medicines have sometimes really held the disease at bay. Very successful treatments with things like lenalidomide for 5q- syndrome, or the hypomethylating agents sometimes have made dramatic impacts for individuals. They live out the rest of their lifespan. They've passed away from other things as they were destined to do. But the concept of remission, whereas we really see no evidence of the disease, that tends to be more limited to stem cell transplantation.
Thank you. And there's a question here related to how does a patient know what stage of MDS they have? It seems quite complicated.
It unfortunately is quite complicated. It's less categorized by stage. We have numerical staging really primarily for solid tumors, breast cancer, colon cancer, pancreas cancer that relates to the geography of the disease. Which organs is it in? In the blood, since the blood is very free flowing, we don't really have stages. What we do have are risk groups, meaning how threatening is the disease from lower risk to higher risk. And your doctor will use, again, I had shown some of the examples of those, but there are many different prognostic scores related to features of your disease to give you a sense of whether you have high risk MDS, intermediate, or lower risk.
Thank you. And as a final question here, what causes the various mutations such as TP53, and can they be halted, slowed, or reversed?
This is really a critical question that really is a great focus of the research. One, we know that the development of mutations is in part due to the process of aging. Indeed, if we looked at the blood of everyone in their 90s, many of them have genetic changes in the blood that we call, quote, clonal hematopoiesis, of which only a small subset end up having a negative impact on the function of the bone marrow, leading to a disease, an MPN, MDS overlap syndrome, MDS, MPN, AML, or others. So we think aging is one of the drivers, with potentially other factors impacting that. Some of them that may be environmental, dietary, or others, some that we don't fully know. Clearly, our efforts are to try to understand how can we slow that process down or potentially eradicate them. There is in parallel ongoing efforts with gene editing studies with CRISPR to see, can we fix genes if they are broken? Can we fix more than one gene? These studies have started with disorders such as sickle cell anemia and bleeding disorders, but these are areas of intensive research that may have implications across many diseases. The one that was raised, TP53, is a gene repair gene that again has implications across many types of different cancers. So it is very possible that breakthroughs in a completely unrelated set of cancers may have implications for even the blood cancers that we have discussed today.
Thank you, Dr. Mesa, for sharing your time and expertise with us today. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family for the past 38 years. This concludes the session.
Thank you.